Edoxaban in ENTRUST reached non-inferiority but did not reach formal statistical significance for superiority with respect to bleeding. This is different with those results that we observed from the prior trials with DOACs. How do you explain the difference with respect to the prior trials?
To your question, certainly there might have been a play of chance, but also the trial design can come into the game. Because if you've seen with the S-type curve for the primary bleeding outcome in the vitamin K arm, we cannot escape that there is a phenomena going on in the first 2 weeks, and there is a potential under-treatment in the vitamin K arm. One. Secondly, as you have recognized as well, the triple therapy in this trial was up to 66 days for the vitamin K arm. There again, this is shorter as compared with the other trials and could have explained, at least partially, the trial results.
In the meta-analysis that has been published by your group, and in a second meta-analysis that has been published during the presentation by Dr. Lopez, there are actually two inconsistencies. In your meta-analysis, the Edoxaban treatment seems to be heterogeneous as compared to the other 3 treatments, and this was not the case in the data presented by Dr. Lopez. So the final question is Edoxaban a different animal as compared to the other 3 DOACs, or is there a consistency in between them?
This is a very good remark, but I have to point to the fact that the 2 meta-analyses are different in structure. So in the updated meta-analysis done by Dr. Lopez, all potential arms from the Augustus trial are considered. In the meta-analysis that has been included into the trial into context, we only considered the relevant arms, so the direct comparison of the NOACs with the vitamin K. That's one thing. And the second thing is we have to be careful with meta-analysis in this patient population, because the intrinsic elements of the meta-analysis, being the trials, are totally different by design.
A signal towards an increase in stent thrombosis have been observed in several trials now. Do you think this is a statistical trick or it is a real clinical issue?
This is, of course, the golden question. Stent thrombosis, I think the signal is real. We have to dig a little bit further into the different trials that have been published up until now, but at least also from these trial results, with a numerical trend in the direction of more stent thrombosis, this should urge us to cautious. I think the signal is real indeed, and we should adapt our therapy up to that. In the combination with clopidogrel and aspirin has been tested in most of the trials, this means that we should look carefully to the duration of aspirin. 1 month might be too long, but stopping immediately after the index procedure, I think that's too short. So we have to come up with an optimal sweet spot, and this might be 1 to 2 weeks after the index procedure, and might be adapted also to the clinical profile of the patients, being the complexity of the procedure.